Please, Lisa, you
I sure am. Are you able to hear me?
there? I'm having a hard time hearing. I don't know if it's everybody else does.
Okay. Is everyone able to hear me?
I can hear you.
I can hear you fine.
Okay, great. Excellent.
Mm, I'm not able to hear you.
Okay. Do you want me to keep talking with you?
Stop this one. Test, test. Do you hear me?
I hear you great.
I'm not
Yeah.
able to hear you.
Okay. Is anyone else hearing me?
Except me.
Is
This
it
is
soft?
Jane. I hear you.
Excellent. Thank you, Jane.
No problem at all.
What's that?
Check, check, 1, 2. Are you guys able to hear me? Lisa, can you go again? I think I
I
figured
sure
out.
can. I
All
hear
right.
you.
Sorry, I think my speaker went mute for some reason. I apologize for that.
No
So,
worries.
so much for testing early, right?
It's all right.
All right, thank you. So, good afternoon, everybody. Thank you for coming at a new edition of the Florida Healthcare Simulation Alliance. Today we have our distinguished speaker, Lisa Brown. She comes from St. Mary Medical Center in West Palm Beach. She is a nurse by background. So she's going to be talking a topic that is very unfamiliar for me, and I'm looking forward to hear what she has to say about this. It's regarding the high fidelity simulation for RRT risk, identifying and enrollment of hyperbaric oxygen treatment for brain injury. I would really find this topic really interesting, so I'm looking forward to hear what she has to say. And right after that, we will have a little introduction by Desi Mercado regarding our next meeting, which is going to be live in Jacksonville. So I want to give her the opportunity to give us a little preempt, entry of what she's preparing for us in Jacksonville. So without any further ado, I'll let Lisa go ahead and start her presentation. So.
All right. Okay. Is everyone seeing my screen? Just the title slide?
Yes.
Excellent. All right. Well, I'm really looking forward to meeting all of you. I'm somewhat new to the area. I relocated here a couple years ago, about 2.5 years ago, from Minneapolis, Minnesota, Hennepin Healthcare Simulation Center, and just kind of getting my feet wet in the simulation community here in South Florida. I'm here just to share some experiences over the last 15 years, actually, with hyperbaric and TBI, and specifically, most recently, some great collaborative work here at St. Mary's in preparing to be an enrollment site for this study. So I'm just going to really briefly discuss the study itself so that you have an understanding of why simulation was required for this study, and then talk about how simulation, and particularly high fidelity simulation, helped us to identify hidden hazards or latent risk threats in the environment prior to being enrolled in taking subjects for the study. Sorry about that. My whole presentation went away. My bad. Give me just a minute. All right. Okay, so a little bit just about the background of simulation. I know we all do simulation. In particularly, there is a lot of research in education and training and assessment, but evidence on its utility in preparing for clinical research is somewhat limited. And I found an interesting article by Woods, Dixon, Woods, and Lame about using simulation to improve quality and safety in healthcare. And I know that that has been in a few studies, but I'm not really going to get into lit research. I really just want to share our experiences. So first off, a little background on severe TBI. As we all know, we know severe TBI has some high economic costs and high costs for patients. We know that the brain is highly susceptible to severe TBIs. We know the costs of TBI are huge and measured in the tens of billions of dollars, and that, you know, there are no real particularly successful standards that is saving patients from severe TBI. And part of it is because TBIs can be so complex and varying. And we know that in the initial stages of injury, that is where we are finding reduced O2 delivery and where all the damage occurs inside of the brain. So previous studies I have had a chance to be part of at Hennepin Healthcare and several other published sites in neurosurgery have taken place about the benefits of hyperbaric in previous trials. And what they've found is that with hyperbaric and hyperoxygen, there is an increased O2 delivery in the plasma, which is improving that energy production in the brain that reduces ICP and the intracranial hypertension that is often the cause the patients are generally close to adults, so 16 to 65 with severe TBI with a GCS of 3 to 8 on admission to the emergency department. If the GCS is 7 or 8, the mortar score 5, the CT needs to be greater than 1. Additionally, consent needs to be obtained. And here's the big thing about this study is that if they're having a craniotomy or a major surgery, they have up until 14 hours to get to their first hyperbaric treatment in order to be successfully enrolled. If they do not require a craniotomy or major surgery, their time to get to their first treatment is 8 hours. Exclusion criteria you can read there. So I think all of those exclusion criteria kind of make sense. The treatment arms for this particular study are listed here. So basically, once the patient is randomized, they're put into a web DCU by the research coordinator, and out pops their assigned treatment arm. And basically, based on their treatment arm, they will go to hyperbarics for each treatment at their particular treatment arm at the specified pressure listed on the arm. And they will be there twice a day for a period of 5 days, excuse me. So they will go to the hyperbaric chamber approximately every 8 to 12 hours for 5 days total, for a treatment total of 10 dives into the chamber. If there's any questions about any of the treatment arms, I'm happy to answer them afterwards. So latent risk threats. So a long while back when this study actually started, it wasn't too long ago, actually in 2018, one of the PIs on the study while I worked at Hennepin came to our simulation center. And because of the high risk nature of the care for these types of patients and the fact that it was a multi-site study throughout the US, the team really wanted to require high fidelity simulation. And so over a period of 2 to 3 months, we practiced at the primary site at Hennepin, doing simulations and writing them and really coming up with what we thought would really help prepare the sites. And so just what are LRTs? So latent risk threats are system threats or elements that make the individual errors that might occur in patient care more prevalent and causing more harm or risk of harming the patient and causing complication. LRTs can include things like processes that are not in place, outdated policies or lack thereof policies, and then of course, like gaps in knowledge and skill, competency, including equipment issues or supply issues. There are things like hidden hazards. And so in this particular study, what you have is you have a complex nature in the sense that this is a really severely ill TBI patient in an acute phase of arrival to the hospital. And the complexities that come with the handoffs of care between the interdisciplinary teams are inherent for communication or role confusions. And then you throw in things like going into a hyperbaric chamber. Hyperbaric chambers aren't all generally set up to manage and take care of critical care patients. And often these sites would need multiple logistical changes and then training on equipment in order to actually care for patients with arterial lines and ventilated and so forth. And so because of this, the PIs did decide to require high fidelity simulation. So one of their, actually the 3 main reasons that they wanted to require SIM are listed here. So the protocol, because it's funded by the NIH and of course oversight by CMS and the FDA, the adherence to the specific protocol is a really big priority. In addition, the protocols and checklists and care checklists for each of the different disciplines were really set up to really prepare and really prevent complications. And they really felt like requiring high fidelity SIM would really help them to prevent complications and then prepare just in case those patient complications might occur. Complications that we're concerned are, of course, cardiac arrest, brain injury, spontaneous bleeds, spontaneous pneumothorax, and then even things like oxygen toxicity due to being in the hyperbaric chamber. Additionally, all sites were required before they could actually be approved for enrollment. They were required to run simulations and track their LRTs and their plans to mitigate and how they fixed those LRTs. And so that's really where the magic happened, was the work that would take place after the simulation once we discovered where all the problem areas were. So what we did at Hennepin prior to starting all the training for all the sites is we provided, the foundational didactic and equipment training. We created teaching videos that showed simulations taking place in the principal site at Hennepin. We wrote simulation documents and debriefing checklists and sim checklists for each site to be able to download and debrief and adapt for their area. We performed interdisciplinary simulation group debriefs, and then each site was required to practice caring with all of the interdisciplinary staff, such as trauma doctors, respiratory therapists, trauma nurses, ICU staff, neurosurgeons, hyperbaric techs, and RTs, how to practice enrolling these patients in a high fidelity simulation. They also were required to complete 1 to 2 complication scenarios that they felt their supervising physician and team would be most concerned about handling, so that they could practice that in a high fidelity manner. And after performing the simulations, they would record their final simulations and submit records of all of their identified LRTs and solutions. The website has all of those documents that they're able to download and use, and would have weekly calls with the PI sites in order to help them get going. So the journey at St. Mary's has been an amazing journey. At the start of 2021, I received a request from the hyperbaric department and trauma surgeon to help with simulation and to help with this study. What the great thing about it is that it actually came from the site that I worked at for 22 years. So it was a great, strange consequence that was quite ironic. In my previous clinical days prior to this particular stage 2 clinical trial, I took these actual patients in the previous research studies to the chamber. So I was actually involved in the patient care end of this. So this was kind of like coming home. St. Mary's Hyperbaric Chamber is an emergent hyperbaric chamber. It's the only one in the county. So they do a lot of decompression sickness, diving injuries, gas gangrene, carbon monoxide poisoning, and, your routine hyperbaric wound care. They had just started their work on taking care of more critical patients, but had a lot of room to grow in the sense of getting ready for taking a patient to this level of care. You can see the pictures on this slide that show their multiplace chamber. So I'm just going to hover my cursor right here. This little tiny spot is where the attendant actually sits inside the chamber. And here's one of our hyperbaric techs here at St. Mary's as we were getting ready to go with our simulation, just getting all of his supplies ready. This is a picture here from one of our first interdisciplinary simulations, where we were practicing taking the newly admitted trauma patient with multiple injuries, including bifrontal contusions, who had about an hour left to get into the chamber. And so you see the trauma surgeon holding the checklist, kind of leading the team so that they know the work that they need to do. So basically, over a period of about 1.5 years, we performed about 12 interdisciplinary simulation sessions. Most of them occurred on Saturdays and Sundays when all the staff were going to be present. And during each simulation session, we performed the protocolized patient, and then we practiced complication simulations. It was amazing work, and we learned a lot. During our simulations, we found that we needed more additional training on the competencies using the ventilation, how to manage ICPs, how to use the new hyperbaric pumps, how to use a Lycox monitor, and all this new critical care equipment. In our simulations, we logged 64 individual latent risk threats, and we were able to mitigate these or eliminate these. And without simulation and without requiring simulation, I can't imagine what we would have confronted. So certainly, I'm a great believer in using simulation for high-risk processes prior to, actually carrying them out with patients. Here is just a quick summary of the process improvement changes that happened with our simulation and debriefing. We were able to get some additional funding for staffing. We also were able to get some additional training funding to assure that all staff were trained in hyperbaric medicine, following best practices and guidelines. They were actually able to hire a hyperbaric lead safety technician, which has been a great addition to their team, assuring best practice standards and safety standards. And then all these policies and procedures and checklists were developed in part after each debriefing session. We were able to take them through and make sure that, leadership or which department was really going to head up the change. So some great changes. Moreover, I really want to talk about the teamwork and the competency changes that happened in doing these simulations. While doing this work, we took about 6 different teams who had never really worked together at this level for this type of critical care, and there was increased engagement. We had an understaffed ICU department at that time who was quite hesitant due to, of course, being understaffed in the ICU. And once we could get them at the simulations and really gain their input, the excitement started. The teamwork that has come out of these simulations is just amazing. Really healthy, problem solving, respectful teamwork, engagement in process improvement. And there's really been an increased perception of safety in the environment and in their own units. The confidence and competence that these simulations provided really assisted them with their first 2 subjects. And thankfully, the site was actually successfully approved for enrollment back in June. And they've had 2 subjects thus far. One was sort of a single head injury that had a really complex, very grave injury, who I think presented actually with a GCS of 3. We actually didn't expect him to survive all of his dives. And we found out from the research coordinator recently that at his 3-month follow-up, he is reporting being at 75% of his pre-injury baseline, which is absolutely amazing. Our second subject, I believe, is still taking and doing acute rehab. And so we haven't really heard much about his follow-up on that. But these patients are followed up for a long period of time. And, we're really looking forward in being part of this. I love these 2 pictures here. This particular tech, who I just really love in the hyperbaric chamber, was really quite nervous about, doing all these simulations and really didn't trust the process. And by the end, she was laughing, and a big part of the fun and the processes and engagement. And these 2 leaders here, this is our medical director and trauma surgeon here at St. Mary's Medical Center, Dr. Brago, who has been just a pleasure to work with, and our director of hyperbarics, Megan Kasabe. So this was the end of our video, and they were happy as could be that we could, get our enrollment, et cetera, in the actual study. So basically, that's all I wanted to share, was just, really looking at how in situ simulation and process improvement simulation just makes such a difference with, something as high stakes as this actual study and the type of care that takes place at this site. So I hope there are some questions. I hope that this was interesting to you. Look forward to hearing your feedback.
Thank you very much, Lisa. I did find it very educational. it is. I do have a question. You mentioned that this is a high fidelity case, right? What kind of simulators you use to do the patient part? Were you using any particular mannequin or?
Yeah, so that's a really good question. So we used, for many of the simulations, we used a nursing Anne. We did also have other Laerdal products as well, other SimN. So like the 3Gs. But in particular, I think the thing I wanted to share, I recently had a conversation with the PI director on the study just to kind of check in with him. And I asked him how the other sites did if they did not perform high fidelity simulations. And he mentioned that about 6 or 7 of the sites, when they submitted their videos, he could really tell, that they were not using high fidelity and they were rejected. And thankfully, they were rejected because they were given the work to actually do things in a high fidelity manner, because you have to hook things up, you have to assess the environment, you have to test every bit of the environment and engage staff in such a way where it feels real and the consequences are seen with changes within the mannequin and or changes with vital signs that would display on the monitor, etc.
Yeah, thank you. Following up the chat, there's a question from Dr. Randall. How long is this study contracted for?
Let me look at the question. I'm sorry. How long is the study contracted for? So originally, Dr. Randall, it was supposed to be a 3-year study, but due to COVID, it was extended another 3 years. I'd actually have to get with Dr. Galen Roxwald to confirm their end date, but I believe that they have a couple of years left on this study still.
Okay, thank you.
Yes, you're welcome.
Anybody else has any questions? I do have a question there. I noticed that this is a simulation that is inside pretty much, right? All the equipment that you guys use is the real hyper chamber, correct?
Mm-hmm.
And also I noticed that I saw one of you mentioned the one person that was very reserved about getting inside. Is it usually a normal practice to get the tech inside with the pressure?
Yeah, that's a great question. So all of the sites vary incredibly in the sense of their logistical layout. The site that I came from originally at Hennepin Healthcare has a multi-place chamber, which it is literally the size of a room. That is not common. So most sites have a very similar looking chamber where there is room for one attendant. And so if you think about that, you have one attendant who has as far as a reach to about the neck of the patient, and everyone else is on the outside. So this is where the complexities of the training and the individual sites really come into play. So in this situation, there's a really small space in their chamber, and that is why we had repetitive training sessions to assure that every hyperbaric tech that could go in there with a patient would feel confident and be able to manage the Artline bag, opening the ICP, ventriculostomy if the patient's ICP raised, checking a blood gas. The medicines are ran from the outside of the chamber on hyperbaric pumps and pushed through with pressure tubing on the inside. And so when the patients would actually start out to being able to be loaded into the chamber, all of the meds one by one would have to be exchanged from the non-hyperbaric pumps to the hyperbaric approved pumps. So there's a lot of logistical issues because companies do not make hyperbaric approved critical care equipment. And so I think once this research gets to its stage 3 level, then there'll be able to be more adaptations to chambers to allow for this type of care to be performed safely.
And when you do this simulation, do you actually do the pressure and a follow-up for that? Is if in real terms, how long a person
Like how?
that the procedure would be inside the chamber?
Yes. So that's a great question. Depending on the treatment arm, the time to get to the prescribed pressure, so it could be, atmospheric pressure where they're not actually going into a depth in the chamber. It could be 33 feet. It could be 65 feet below sea level. So the time at which the dive tables are all timed on how fast that's appropriate following the Navy diving tables, how fast you should actually proceed to get to that treatment stage. Once you get to the prescribed treatment protocol arm stage, they stay at that site or depth, I should say, for 60 minutes, and then they come up. So here's where the complication sims are really important, because what if you have a patient who has a sudden spontaneous bleed? You have 3 minutes before that patient, 3 to 5 minutes before that patient is actually outside of the chamber. If you have a cardiac arrest, you have 3 to 5 minutes before that patient's outside of the chamber. So this is why research is needed on how to ready different sites to make sure that they can perform this care, and that it is in fact really going to make a difference in severe TBI, which I really feel like we know that the evidence is there. It's just such a complex care.
Thank you. Anybody else has any questions for Lisa?
Yeah, what are the effects of dropping somebody from being, under pressure to all of a sudden you open up the hyperbaric chamber and pull them out to, say, deal with a bleed or something? How do they deal with that rapid decompression?
Yeah, so for every depth, there is a protocol and procedure on how to come back to atmospheric pressure. So it's very procedural. It's almost military procedural. It's every dive has a chart and a plan for that. The effects that you need to worry about are, of course, pneumothorax, lung injury, are some of the biggest things that you need to worry about. So, those are things that are assessed as the patient is being brought up. Everyone is looking on the outside. How does that chest rise? Everyone has a plan as soon as that door opens, what their role is on assessing where they're at from complications. And so almost every site did a cardiac arrest or spontaneous pneumothorax or tension pneumothorax complication. The other thing you have to realize, if someone goes into sudden cardiac arrest, that whole environment is filled with oxygen. So you have to remove them from that area, often the entire room, before you can use a defibrillator.
I didn't think about that, but yes.
Yeah. So what I can say anecdotally, taking these patients 15 years ago when everyone thought this was absolutely crazy, was anecdotally, I could see the changes that happen. I have no doubt that the research shows that there is significant benefits with hyperbaric treatment. The question is, at what level and how much oxygen should they get? Should they get 4 hours of hyperoxygen at 100% immediately following their treatment? Should they not? What types of circumstances should we consider? Patient circumstances, et cetera. So there's a lot of really interesting science and discovery to have with this. I can't imagine ever taking a patient without doing simulation with this type of care. And you know what? I did it 15 years ago and it was painful. So having been through that as a nurse, and then having been through this experience as a simulation educator at a very prestigious hyperbaric chamber, and then being able to apply this at an amazing chamber with amazing staff, but some heavy logistics to work through. I just can't imagine doing it without sim. It just seems impossible. So I'm really happy that they required this level of training, and was happy to provide a lot of resources along with the, my colleagues that helped write the simulation cases that are on the website.
Anybody else has a question for Lisa?
What's the website?
The website, let me go ahead and share my screen here real quick. See if I can get back in there. I'm still sharing, right?
Yes.
Okay. The website that I would suggest to go to is this one right here. So it's the HOBIT Siren. If you just Google HOBIT Siren, I also have a QR code there. If you're interested, you should be able to scan the screen and it should work for you. I could also email that out if needed.
Okay, I got it.
Excellent.
St. Mary's, I worked at St. Mary's for 10 years, so that's kind of like my stomping ground as well.
Oh, how exciting. How exciting. Yeah, I chose St. Mary's because of the level 1 trauma and the sort of the many other aspects to it. So it's been a really good journey for the last 2.5 years. I'm actually going to be relocating to Cleveland Clinic next month. So
In South Florida?
yeah.
Rego's been there forever.
Yes, I have enjoyed working with him immensely. It's been a great journey. So
So I'm looking forward to, anybody else have any questions?
Lisa, I have a question. It's not so much on the simulation that you did in the thing, but it actually has to do with hyperbaric therapy for the traumatic brain injury. We always learn that if you don't have circulation, the brain tissue starts to die within 5 minutes or so. But yet, you guys put these guys in the hyperbaric chamber, and how does that work? Because does it reanimate the tissues? How does it function? I don't understand.
sure. Yeah, that's a really good question. We could talk quite a while about it. But basically, what it does is it increases the O2 that's delivered to the brain, and it dissolves the O2 into the plasma. And then it's able to be diffused across the capillary endothelium, and it helps with metabolism. And so it's basically just preventing that cell death. And the reason of the timing of the dives is really important because they noticed in old studies that were done previously that if they waited 24 hours, the damage was done. There was not much benefit. So it's all about getting in right away. And that's really challenging if you have a multi-trauma patient with a chest wall injury and an open book pelvis that you're, transfusing blood. And, so it's, certainly it's great to start with some real less complex head injury patients so that you don't have to manage all the resuscitation, but you, in this situation, you don't really know what you're going to get until you enroll your patient.
I'll follow up with that. Most trauma one, do they have a hyperbaric chamber or it's just this particular one that you work in?
Could you repeat that? I'm sorry.
No, it's most trauma one hospitals have a chamber, hyperbaric chamber in there.
Yeah, it really varies. I don't know the data on Florida because I'm still relatively new here, but there aren't a tremendous amount of hospital-based hyperbaric chambers that do critical care. And there are a handful. I think they started out with about 18 sites initially when it kicked off in 2018, some real, big name hospitals, et cetera. I think they lost a few as COVID started because then COVID really, changed everyone initially. But I think right now they have 12 sites that are enrolling. but there are some really pretty strict, enrollment criteria. So, you think you have a patient, you start working them up, and then they don't meet some of the criteria or their status changes. So.
Anybody has any other questions? I do find this whole presentation very interesting. I'm looking forward for the final outcome of the research. So thank you very much, Lisa. I know you have to leave soon.
Yeah, thank you so much, very much. I appreciate that. And thanks for letting me be part of this.
You're welcome. Thank you. I appreciate it, volunteering. Doing the presentation was really outstanding and very open-minded for us. Okay, thank you. So following up now, I would like you guys to invite you. Hold on, let me see. Our next, we are not gonna have next webinars on November and December because we have because of Thanksgiving and the holiday, the Christmas and New Year's holidays. But we are going to have another session on November 4th, and this one will be in person. It's going to be at Jacksonville. Let me see if I can share the. Hold on, let me share the invitation.
Smartphone connected.
So, I lost my image. Where is it? Right here. Share it. So hopefully you're able to see. It's going to take place at the J. Wine Dolores Park Weaver Simulation Center at Mayo Clinic in Jacksonville. It's going to be on November 4th. It should start at 12. Lunch will be provided by the center. So if you are in the vicinity and you had time to be there, please come and join us. It's going to be our first in-person event since COVID. So probably it's going to be also a little bit of a blueprint of future in-person events for this alliance. Okay, so I would like to extend the invitation for everybody to come and join us, and we'll be looking see you probably on Jacksonville, and we will resume our regular webinar after the IMSH conference. Right. So thank you everybody for coming up, and have a great week and weekend for the rest of the day. Thanks.
Thank you. Bye-bye.